Hey, MedSurg students, in this presentation, I'm going to talk about transfusion therapy and blood products. There are many different types of blood products that are used in transfusion therapy. For example, a patient who has lost a lot of blood may get whole blood, but there are also other components. For example, the patient may be prescribed packed red blood cells if they lost blood. They may be prescribed FFP, which stands for fresh frozen plasma. And this has all the clotting factors because packed red blood cells do not have clotting factors. So if you're giving a lot of packed red blood cells, like every 3 units or so, you should be thinking about and asking the provider, is it time to give a unit of FFP? Albumin is a protein. That's another blood product that may be administered. Clotting factors could be administered for people that have bleeding problems or DIC. Chiroprecipitate is also given to patients with bleeding problems, clotting problems, and platelets for patients that have low platelet levels. Again, to reiterate, some of the indications for transfusion therapy would include somebody who has excessive blood loss, like is hemorrhaging, would get packed red blood cells. Somebody with anemia or hemoglobin less than 10 may get packed red blood cells. People with kidney failure, your kidneys produce erythropoietin, which is what stimulates our red blood cells to grow. So if somebody has kidney failure, their erythropoietin is not working. So they may need packed red blood cells. So oftentimes kidney failure patients are anemic. People that have coagulation factor deficiencies, and you'll be learning about that hemophilia in pediatrics, they may need FFP. Thrombocytopenia, which of course we talked about in the cancer lecture, is platelets less than 150,000. But usually platelet therapy or transfusion is reserved for people that have very low platelets, like 50,000 to 20,000. Or somebody with thrombocytopenia that may be having a procedure, they would give it right at the start of procedure, not like an hour before, but right when the procedure is starting, because platelets get eaten up really quick by the body. Hemophilia A would get chiroprecipitate, and then burns and protein. People with low protein would get albumin. For the blood products, we do need to type and cross-match to prevent transfusion reactions. Pre-transfusion, the nurse has a lot of responsibilities. First, you must ensure the order is on the chart, but the consent is on the chart. You would have the patient sign the consent if it's not on the chart. You would have to verify the prescription with an RN. You would test the donor's recipient's blood for compatibility. And what that means is you would look at the donor's blood type and the recipient's and make sure they're compatible. You verify the patient's identity with an RN. So it takes two people to hang blood because it is dangerous if somebody gets blood that's incompatible. There could be a reaction. You want to make sure you're examining the blood bag label, the attached tag, and make sure the RH is compatible with the patient, the RH factor. Check the expiration date with another RN. You don't want to give expired blood, and you don't want to give blood older than 1 week to older adults because it's high with potassium. You want to inspect the blood for discoloration, gas bubbles, or cloudiness because you're not going to give it, right, if it has any of those. You can hang packed red blood cells with normal saline only, and there's a specialized tubing that you use. It's called a Y tubing, and I know you've done this in lab, so you would make sure you have that all set up. And once you go to the blood bank and pick up the blood, the clock starts ticking. You only have 30 minutes to get that blood hanging and infusing, okay? So always make sure before you go to the blood bank, you have the consent, the IV is in, it's patent, it's running, and I set up the Y tubing with the saline before I go to the blood bank. So when I get back from the blood bank, all I need to do is check with another nurse, okay? Go through the checks. make sure you're following your facility's guidelines when starting a blood transfusion, because preventing incompatibility requires strict adherence to blood transfusion protocols. Okay, and blood is typed based on the presence of antigens. So that's very important to know, and I'm going to talk about compatibility in another slide. Okay, med-surg students, do not stress out about compatibility with transfusion therapy. I'm going to break it down for you, okay? The universal donor is O negative, so that means O negative can receive blood, can donate blood to anybody, okay? The universal recipient, in other words, the blood type that can receive all types of blood is AB positive, okay? So, if you can remember this statement, this will help you when it comes to negative and positive blood. So Rh negative people can only receive Rh negative blood. They're so negative, they can only receive negative blood. Rh positive people receive Rh negative or Rh positive blood, because positive people can accept a lot of different people. So they can accept both negative and positive. Okay, so look at this chart here. I'm going to make another statement that's going to make it easier for you. You can only receive blood from your blood group. And if you're positive, you can receive both negative and positive. And if you're negative, you can only receive your blood type negative, okay? So let's go. We're going to just go down the receives from these groups, okay? Because that's usually what you're asked about. What type of blood can this patient receive? So if you're O negative, you can only receive O negative blood. If you're O positive, you receive O positive and negative, because you're so positive, you can accept positive and negative blood. If you are A negative, you can only receive A negative and O negative. Remember, everybody receives O negative. Everybody can receive O negative. Okay, so let's do AB negative. If somebody is AB negative, they can receive O negative, because everybody can receive O negative. They can receive A negative, B negative, or AB negative. Okay, and then AB positive can receive all the groups. Okay, we're going to do a question, so don't stress. The client has blood type B negative. The client's family asks if they can donate blood for the client. The nurse informs the family that they would need to be of which blood type to be considered for a direct donation of RBCs for this client. Select all that apply. Now, this client is B negative, so they can only receive their blood type in negative blood and the universal donor. So I'm going to give you a minute, and you can see if you got it right. So here are the answers. This person is blood type B negative, so they can only receive B negative blood and O negative blood, because O negative blood can go to anyone. Again, more transfusion responsibilities. You have to provide patient education and let the patient know you're going to be with them for the first 15 minutes or even longer when they have a transfusion reaction. They need to be told, they need to report any unusual sensations, like if they get shortness of breath, hives, or itching, okay? You want to assess the vital signs immediately before starting, and then according to your facility's policy. Okay, so the vital signs are really important to get, especially the temperature. Do not leave that out, because if the temperature goes up, they may be having a febrile reaction. So you do need to take a temperature. That's like the most important vital sign to take. And then administer your blood products per protocol. And always, if somebody's getting a lot of blood, monitor for hyperkalemia. You never want to shake the blood around a lot, because it's going to make the blood cells lyse, and the potassium in that blood is going to go up, because remember, potassium lives inside your cells. So if you kind of break up those cells, it's going to have high potassium as well. Again, packed red blood cells are given to replace cells lost from trauma or surgery. Also for people that have anemia or a hemoglobin less than 10. So um, usually each packed red blood cell is about 250 ml, some are a little bit more, the bags I'm talking about. And the patient may be pre-medicated with like acetaminophen and dihydrophedrine Benadryl, okay? And the reason is um, to prevent transfusion reactions, especially for somebody that gets a lot of transfusions, like somebody with cancer. When I worked in oncology, we always loaded them up with acetaminophen and Benadryl before they got transfusions. So we established platelets are given for thrombocytopenia. They're also given to people with active bleeding and conditions like DIC. And anybody with low platelets who is scheduled for some type of invasive procedure, they would be given platelets at the time of the procedure, okay? Platelets get eaten up by the body pretty quickly, so that's why if you're going to do something invasive, you want to give them right at the time of the procedure so that they'll be able to do the work they're supposed to do during the procedure. They're not administered with the traditional Y tubing we do for packed red blood cells and fresh frozen plasma. They're they have their the blood bank will give you the tubing. Usually that's been in my experience wherever you work, it's like straight tubing. You deliver platelets very quickly, like over 15 to 30 minutes. They could be pooled or single donor. Don't stress about that. And patients could be pre-medicated for platelets as well. Plasma, or FFP, is given to replace clotting factors, so fresh frozen plasma. It needs to be delivered or administered within 2 hours of thawing, because if you let it sit out, well, you wouldn't let it sit out longer, but the clotting factors diminish very quickly. So it's infused right away while the clotting factors are still active, and it goes over like 30 to 60 minutes. And it's like done with Y tubing and normal saline. And you need to monitor the prothrombin time or the prothrombin level because that's a clotting factor, okay? And that's what you would monitor if you were giving somebody FFP. Now I'm going to present the different types of transfusion reactions. Pay attention to the onset of the reaction, okay? So first I'm going to talk about febrile, and this occurs about 2 hours into the transfusion. And it results from the development of anti-WCB antibodies, and it's seen in people that have multiple transfusions. Like I was talking about the cancer patients, that's why we pre-medicated them. So the patient will have chills, and they'll have an increase of 1 degree Fahrenheit or greater from the pre-transfusion temperature. That's why it's super important to get a temperature before transfusion reactions. They may develop hypotension and tachycardia as well. So some of the actions, number one, you can use a WBC filter when you're administering packed red blood cells to prevent the reaction from occurring. You would stop the transfusion, administer antipyretics, obviously, and initiate an infusion of 0.9 normal saline using new tubing. So for every reaction, you stop the transfusion, for every transfusion reaction, I should say, you stop the transfusion and initiate an infusion of normal saline. The next reaction I'm going to talk about is a hemolytic reaction, and it can be acute. So it occurs when as little as 10 mLs of blood is infused. This is one of the reasons you have to stay with the patient for 15 minutes at the initial blood transfusion to make sure they're not having a hemolytic reaction. Or it can manifest during subsequent transfusions. So now, an allergic reaction can occur during the transfusion, but it can also take its time and show up 24 hours after the transfusion. So, with any transfusion, after it's all done, you still have to monitor your patient for reactions after the transfusion, okay? So, this usually results from sensitivity reaction to some component of the blood, okay? And findings could be mild, like itching and urticaria, or flushing, Or it could be very dangerous, like an anaphylactic transfusion reaction, which results in bronchospasm and laryngeal edema and shock. So the patient could potentially die from that. So you have to monitor them closely. So if it's a mild reaction, you stop the transfusion, change out the tubing with normal saline, administer the medications that are prescribed, and then for anaphylaxis, stop the transfusion, administer what, depending on what how serious it is, you could give epinephrine SC, O2, CPR, and new tubing. Okay, a bacterial reaction is not that common, but I will say it can happen during or it can happen several hours after. That's why it's super important that you monitor your patient even after you are done transfusion them. The patient will have respiratory symptoms and they can be pretty severe. So obviously if it's during the transfusion, you're going to stop the transfusion, hang normal saline and new tubing, and send the blood for a culture to the blood bank, and then position the client with the feet lower than the heart. Okay, circulatory overload or fluid overload is not a transfusion reaction per se. Like, in other words, the reaction doesn't happen because of the blood products or incompatibility with the blood products. The reaction happens is because the patient got too much fluid, too much volume, okay? They couldn't handle it. So it can occur anytime during a transfusion, even right after. So with older adults, we take some precautions. Like, for example, if we're going to give 2 units, we wait 2 hours between. And I would give an older adult, so blood can only hang for 4 hours. I didn't mention that before. So for an older adult, I would do it slowly over time. For younger people, they can get a blood transfusion quicker, but you cannot let blood hang longer than 4 hours, okay? And that's from the time of the blood bank, okay? So you know what the signs and symptoms are of fluid overload. Okay, you want to slow or stop the transfusion depending on the severity. I'll give you an example. One night I was working and it was the middle of the night, but I had to wake my patient up because I was giving her blood. She was an older adult and I needed to listen to the lung sounds, quite frankly, every hour because I knew she was at risk. And this was like a long time ago, before it was considered a sentinel event to have an older adult go into pulmonary edema while getting a blood transfusion. But she had crackles all the way up her lungs. She was a little short of breath. I called the provider and I was able to give her some furosemide. She diuresed and she was able to continue with the blood. Morphine is a great drug for pulmonary edema and circulatory overload, okay? It relaxes the patient. I know students are always cautious about it because it decreases the respiratory rate, but it really is good for pulmonary edema. All right. You want to stop or slow the transfusion. So if it's a mild reaction, you could possibly slow the transfusion. If it is they're in full-blown pulmonary edema, gasping for breath, you're going to stop it, right? And that's what you're going to do for circulatory overload. Now this question is an ordered response. A client with early acute renal failure has anemia, tachycardia, hypotension, and shortness of breath. The provider has prescribed 2 units of packed red blood cells. What should the nurse determine prior to initiating the blood transfusion? Select all that apply. Okay, I'm going to give you a minute and I'm going to lead you through how you would proceed with a blood transfusion. Okay, the first thing you're going to do is you're going to make sure the patient has IV access. You want a 20 gauge needle. If it's an older adult, you want a 19 gauge needle, but just for the record, I've never seen one, but that's what's in ATI, okay. Anyways, you're going to hang the Y tubing with normal saline because you only have 30 minutes once you go to the blood bank. And if somebody has bad access and you got the blood there, you're going to have to take that time and put the IV in. And as a new grad, that's going to stress you out. So just remember, make sure all your ducks are in a row before you go get the blood at the blood bank. You want to make sure there's a signed informed consent for the transfusion therapy. You want it, again, before you go down to the blood bank. You're going to make sure all blood typing and cross-matching are documented in the medical record. Then you're going to take the vital signs, right before you give it, especially the temp, because we want to watch out for a febrile reaction. There is a second unit of blood in the medication room. We're not even going to use that. And the reason is, you cannot, like, say, you go down to the blood bank and you get the blood, you cannot put it in another refrigerator. If you can't give it in 30 minutes, you have to bring it back to the blood bank. You can't put it on the unit's refrigerator. And the client has an identification bracelet.